Hello. Thank you for tuning into the virtual lecture today. Today we're going to be talking about the axial skeleton. So when we talk about the skeleton, we divide it into the axial and the appendicular. So axial, you can think axis. It's the center line, the head and the vertebrae and your ribs. All the things that are in your limbs, your appendages, that's appendicular, which we'll talk about next week. So today we're focusing on this axial skeleton. Now, when we talk about the skeleton, we need to talk about the origin of bones. And now we've talked before about the gastrula, but here we're talking more about the endochondral versus intramembranous ossification. Does it come from cartilage or does it come from the membrane? The axial skeleton is mostly intramembranous. It comes from in the membrane, although there are endochondral parts. And you can see here, so you can see these ribs, which are endochondral. You can see these cartilage templates and the bones starting to fill in, this red stuff here being bone. And then in the skull, where you're seeing intramembranous, you can see this more meshwork as it sort of starts dispersing through the membrane, as opposed to these solid calcifying spaces in the endochondral ossification. So we're going to start here with the skull. Now the skull is a lot of small bones put together, and we can see them here broken apart. Now in lab, you've seen the skull and you've seen this exploded skull. So we're going to be looking at that. And this exploded skull shows if we separated all of these bones. Now each of these bones is separate because it starts separate, but then as it comes together in the adult, it joins by sutures, which we'll talk more about sutures when we get to joints, but they're fibrous, non-moving joints between bones. And so we have these sutures. There are also some places where there's fusion, where the two bones actually fuse together, like in the frontal bone, which we'll talk about in a moment. So in this fetal skull, so this fetal skull is still membrane. You can see this membrane, you can see through it transparently, and you can see some of the starting points of the ossification. At birth, the plates that will be these bones, these bony plates, are already ossified, but there's still spaces in between them. And these spaces in between them just have membrane there, and the bones come to each other, but they can move around that joint a little bit still. And there are also these fontanelles. The fontanelles are soft spots in between the bones on the baby's head. You may have heard the newborn baby has soft spots on their head. That's what we're talking about here. And these are very fragile points where literally with not that much force, it is possible to push through to the brain. That's scary, right? Why are they born that way? Well, the reason is that babies have to fit through the birth canal. And the birth canal is very narrow, and having this flexibility here allows the head to actually squish and compress in order to pass through that birth canal. In addition, these spaces allow the skull to grow and leave room for the brain as it grows. So this allows for the birth process and the growth process. Now, what's interesting about this is because it's so flexible in the way it comes together, the skull can actually be changed in shape in babies. So we know now that babies that sleep on their stomachs are more likely to experience sudden infant death syndrome. So parents are told to put the babies to sleep on their backs. But because of this soft head, babies that spend a lot of their time flat on their backs can actually develop a flattened spot on the back of their head. This has been done intentionally in some cultures with some very dramatic shaping, with binding of the head, or just with leaving the baby pressed up against a baby board for carrying a lot of the time. And these were considered desirable head shapes. What's interesting is that these actually don't cause a lot of complications. In general, these people have fully normally sized brains, normal intellectual function. There's some evidence of like slight complications with circulation of the cerebrospinal fluid, but mostly it doesn't matter. Like these sorts of reshaping of the brain of the skull, people are just fine. It's mostly a cosmetic thing. So this incredible flexibility of our skulls when we're born allows for these drastic changes. All right, but as you get older, these bones come together to form these sutures, and these sutures have this little pass back and forth, and this interweb of bone with fibrous tissue in between it. So here we're looking at the sagittal suture, the coronal suture, the lambdoid suture. So, but we're not going to worry too much about each of these individual sutures, but this suture here forms a non-moving joint. And within the suture, we will actually see some of these sutural bones. And the sutural bones are interesting because everyone's going to have a slightly different arrangement of sutural bones in their skull. These bones just arise as these fontanelles are closing and these sutures are closing. We get these little tiny bones forming up. And so everyone's suture pattern is just as individual as your fingerprints. Everyone has a slightly different suture pattern. When you're in lab, hopefully you'll get a chance to look at a couple of different real skulls, not just plastic ones, and get to see some of these differences in suture patterns. Now, the frontal bone starts as two separate bones separated at the midline, and then it comes together. But instead of forming a suture here, it actually in adulthood fully fuses into one solid bone, unlike all the rest, which you leave those sutures. So now we're going to actually start walking through the bones of the skull. So starting from the back of the skull, right back here, we have the occipital bone. The occipital bone has a few distinctive features. It has the foramen magnum. The foramen magnum is where your spinal cord passes through your skull down into your vertebrae. And it has the occipital condyle where and the condyloid condyle, these are where it actually rests on your vertebral column. It also has fossae here, indentations in the bone, which is where your brain rests against it. So this is forming that back bottom part where your brain is resting in it and your head is resting on your spinal column. Then we move on to the parietal bone, which forms this side, so right along here. As I'm going through this, I really recommend feel these physically on your head. Put your hands on these bones. It helps a lot. So that's right here. It again forms part of that brain case. We have the frontal bone, which is that distinctive one that I told you that grows together in the center. And the frontal bone forms the brow ridge. It forms the tops of your eye orbits, so with that supraorbital margin. And inside, we can see again that those fossa for the brain case. We'll also see these supraorbital foramen. Wherever you see these foramen, that's usually where nerves are passing through. So this is passing through to allow the movement of these muscles that are on the top half of your eye sockets, moving your brows, moving these muscles, allowing the movements of facial expression and eye control here. Then here, around your ears, is the temporal bone. The temporal bone here has the acoustic meatus. So that's where the opening for your ear is. And we're also seeing it come in to form part of this maxillary structure with the jaw. And you can feel the temple, where you think of your temple, that's really the area of the temporal bone right there. Coming in, we have the sphenoid bone. And the sphenoid bone is forming sort of the centerpiece right here in between. Again, there's a lot going on. It's got a lot of different structures. You'll see this much more in lab, so I'm not going to go into them in a lot of detail here. There's a lot of structures for all the things that are happening in your head here in that middle part. We get to the ethmoid bone. Now, the ethmoid bone is one of our few pneumatized bones. It is very light. It has air running through it. This forms part of your sinus, where air is actually running in through this bone in your sinus, and this forms this internal space where you can see all these thin layers here. That's that pneumatization with the air in the middle. Birds have all of their bones pneumatized. We just have the one with the sinus. So then that sort of takes us to this facial bones as a whole. So we can see some of the bones we've already discussed, the frontal bone, and the temporal bone we're going to look at here. There's the zygomatic bone with the cheeks here. We have the vomer in the central bone in your nose. So we've got all of these different bone structures that are making up this area. Here we've got the maxilla, the upper jaw, and then the mandible, the lower jaw, which is, of course, the one bone in the skull that actually moves. Looking inside the nose, we've got a sliced open nose here. So we've got the ethmoid bone that we were talking about. We have a nasal bone up here on top. You feel that bony part right before the cartilage starts. We've got the cartilage of the nose. So that's just cartilage, not bone here. Everybody's nasal bone ends in a slightly different place. You can sort of feel that. We've got the vomer that we talked about. Here's the maxilla here. And then we're coming back into the sella turcica. So in the sphenoid bone. So that's the inside there on the nose. Now we've got this mandible. So the mandible, of course, is really doing a very different job than the rest of the skull. It's important for movement. It needs to chew, right? Your maxilla is just holding in place, and your mandible moves against it to chew. So we have the teeth. We have processes that attach to the joint itself and to the muscles that are involved here. We have the foramen that once again allows the nerves to pass through to get to things like your lip that need to pass through that bone. And so it's also a very sturdy bone with this thick body that allows it to handle the forces of chewing. All right, so those are the bones of the skull. Moving down, we get to the hyoid bone. Now, the hyoid bone is a weird bone. It's this one bone that isn't attached to anything else. It just sort of floats there. It doesn't join directly to any other bones. And one interesting feature about that is the hyoid bone is frequently broken when people die by strangulation. So a broken hyoid bone is an indication of compression or significant force right around the throat, because there's really no other way to break that. It provides a structure for the cartilage of the larynx, which we'll talk about more later as we go on. And it provides a structure for muscles to attach to, these muscles that are important for moving the tongue, for moving the cartilage in this area. So this bone provides this structure that's just floating there. It actually evolved from our gills in fish. All right, so now we've finished up the skull and the hyoid bone. We're going to move down from here into the spinal column. So in the spinal column, we divide the spine into different sets of vertebrae. So we have the cervical vertebrae in your neck, the thoracic vertebrae that run down to your diaphragm, the lumbar vertebrae in your lower back, and then the sacrum that is part of your pelvis, and then your coccyx, your tailbone at the very end. Now, these sections have specific curvature that is important for holding us upright. Now, a four-legged mammal has a very simple spine curve it can be more straight, it can go a little up, it can go a little down, but because we basically took a four-legged spine and turned it on its side, we arced the curve, which means we now have this S curve where it goes forward a little bit, back, forward again, and then back again, making this weird arcing S. And of course, that is part of why people have so many issues with back problems. And in terms of abnormal curvature, we can look at three different types of abnormal curvature here. So we have scoliosis. Scoliosis is where it's curved from side to side. There are probably at least one or two people in this class with scoliosis, at least mild scoliosis. It's very common. And as long as it's caught and treated early, for most people, it isn't a big deal. But it can cause very severe deformities if either they aren't able to treat it effectively or if it isn't caught early on. There's kyphosis, which is a hunchback, leaning forward. And then there's lordosis, with being sway back, arched backwards. Lordosis is normal in late pregnancy when there's a lot of weight in the abdomen. It can also be seen in people with hypermobility, or sometimes simply in people with abdominal obesity with a lot of weight carried in the abdomen there. So now to look in a little more detail at these vertebrae. Each vertebrae, we have the vertebral bone, and that it articulates with other vertebrae with this disc annulus. Sorry. The intervertebral disc here, the disc annulus, is a thick disc of cartilage that sits in between the vertebrae and provides cushioning and allows for the gaps that allow the spinal nerves to come out through the side. Now, the vertebrae themselves have a basic structure that is going to show up in most vertebrae, but each set of vertebrae has slightly different structure. So what we'll see here, we'll see the vertebral foramen. In this vertebral foramen, that's where the central nervous cord actually passes through. So that is going to pass right through that foramen. There's the body. The body is where it's sitting on top of the other one with that disc in between. So we've got this nice big space for the body to sit. There are processes coming off that muscles will attach to, and that also can be important for providing space and structure for guiding where those nerves are going. And each of these integrates very neatly with each other. When you put this all together in the lab, that's really going to help you understand how these fit together. You'll see that as you actually assemble skeletons in the lab. So the cervical vertebrae are distinct. They have a much smaller body. They have a bifid, or this bifurcated spinous process here. And they're curved to allow for spinal nerve passage. There are a couple of very specialized ones at the top, the atlas and the axis. So the atlas doesn't have a body. It's not in this basic structure. It's a very distinct space. It's just got this opening and a little space that's actually going to allow it to hold the skull on these facets, and an opening here for the dens, which we'll talk about in a moment. And so this is where the atlas holds up the world. This is where your skull actually sits directly on your vertebral column there. Coming down, we get to the axis. The axis, again, it's an axis. It's what it sounds like. It allows for the turning. So it has this dens that sticks up, and the atlas basically sits on the axis and can spin around the dens, allowing you to turn your head. When you turn your head, that's what's happening. It's spinning around that dens. It also has these articular facets that set there like this, and then at the bottom, it has a body starting that spinal column that it can sit on top of C3, which is a normal cervical vertebrae. Now moving down to the thoracic vertebrae, in the thoracic vertebrae, the spinous process coming off the back is long and projects downward. It overlaps these vertebrae, providing extra sort of protection and structure here, strong places for muscle attachment. It also has articular facets where the ribs connect up. Moving down, so you can see here where the ribs connect right here. The tubercle of the rib connects up to this articular facet for the rib. And so we can see that connection. You'll see that again when you put these together in lab. Coming down to the lumbar vertebrae. The lumbar vertebrae have a large, thick body and a short, round spinous process without that long, sticking out articulation here. They're big, they're solid. These need to hold up the weight of the whole upper half of your body. So these are big and solid. They're mostly just sturdy. You will really see that when you get your hands on them. Now coming down to the sacrum, this is different. Here they're actually fused together by the time you're a full adult. These are fused together and they form part of your pelvis. So they actually here have a joint, a sacroiliac joint with the ilium of your pelvis. And so they're very structurally different. You can sort of see the outlines of what a vertebra was, but it's all fused together as part of this sacrum. At the bottom, then we have the coccyx, which is our tailbone. It's the leftovers of what would be a tail in most mammals, but in us, it's all internal and very small. It's essentially just vestigial. So here's our coccyx again. You can see it curled in. Now, this is going to look a little bit different in males versus females. We'll take a look at that as we continue on. All right, so back up to the thoracic section, we have to look at the ribs. So the ribs in the back, we have that articulation that you saw on the vertebrae. In the front, we have the sternum. So the sternum has three parts. It's got the manubrium at the top. You can feel these if you just take your fingers and feel it on your own body. You can feel the manubrium, and there's a little bend. We get to the body, and then at the very base, there's the xiphoid process. Now, the xiphoid process just sticks out a little bit, and it is at least partially cartilaginous in most people. So this ossifies slowly over the course of your life. So the manubrium and the body actually have a cartilaginous joint in between them that if you sort of stretch back, there's a little bit of movement in there, and that allows some of that flexibility. The sternum itself begins fusing together around puberty. So the fourth and the fifth joints fuse soon after puberty, but the second and third actually fuse slowly between puberty and about your mid-20s. So many of you, they're probably not yet fully fused. There's still a little bit of unfused cartilage in there. And then once again, that xiphoid process remains partially cartilaginous for most of your life. All right, so we've been talking about this. The ribs here are this part of the part of the axial skeleton that actually does have that cartilaginous, that and the sternum have that cartilaginous origin. So the ribs, these ribs, we can divide into true ribs, false ribs, and floating ribs. The true ribs, so all of the ribs articulate in the back with the vertebrae. The true ribs articulate onto the sternum. Now, there is a fair amount of rib here that is still cartilage in between. So there's that cartilage space between the bony rib and the sternum, but it connects directly one for one here. When we get down to false ribs, the false ribs don't connect one for one. Instead, they connect onto the cartilage of the true ribs and from there up to the sternum. And then we get to the floating ribs that don't connect at all. These floating ribs can sometimes be a high risk for being dislocated or broken because they're not as sturdy and attached. All right, so that's the end of what we're talking about today. There is an activity on Blackboard that you should have gotten an email about, and we talked about on Monday, that you can either do independently or with your team. So go ahead and take a look at that activity and get started on that. And if you have any questions, please reach out to me. I'm happy to talk to you, and I will see you all next week.